But welcome everyone to our primary care panel. We have three wonderful panelists who are here. So I'm going to have each of them introduce themselves, and then I have a set of questions that I will ask the panelists. And then if anyone has specific questions they'd like me to ask, you can go ahead and private message me and I can ask when I'm asking the panelists. And then hopefully at the end, if there's time, we'll do breakout groups with each of the panelists. So why don't we go ahead and start with Dr. Wasim. She's here to introduce herself. Awesome.
Assalamu alaikum warahmatullahi wabarakatuh. I'm really glad that you guys are doing it. I wish you all very good luck. I myself is an internist. I actually did my residency at Rutgers. It used to be UMDNJ actually, long time ago. And I've been in private practice. My office is in Teaneck, and I'm affiliated with Hackensack Hospital in Hackensack and Holy Name Hospital. And I basically treat everybody from 15, 16 years old to 101 is my oldest patient.
Oh, awesome. Okay, Dr. Ahmed, how about we have you go next?
Assalamu alaikum. I apologize if there's any echo. I'm currently driving. My name is Ahmed Hussein. I am at University of Michigan right now doing my ultrasound fellowship from emergency medicine. Just completed that, alhamdulillah. So going to be starting my second year of practice in Chicago coming up soon. I did medical school at Rush in Chicago, did my residency in Yonkers in New York. And I'm looking forward to seeing whatever questions you guys have for us.
Awesome, thank you. And then we have our final panelist, but certainly not least, Dr. Tasfia.
Assalamu alaikum, everyone. I'm a third year family medicine resident actually, but I'm graduating this weekend, so I'm excited. So I'm actually from Canada. I did my bachelor and my master's in Canada, and then I did my medical school in Missouri, and I'm doing my residency here as well. And then inshallah, I'm moving to Boston, where I'm taking my first job. So we'll see how that goes. But I'm interested in like all ages for family medicine, and so with like a focus on women's health. So that's what I'll be doing in my practice. So I'm looking forward to your questions also.
Wonderful, thank you so much. So our first question, whoever of our panelists wants to answer each question, you can go ahead and just jump right in. But our first question is, why did you choose primary care or your specific specialty?
I can answer at least my piece, and then maybe other people can chime in also. But for me, when I knew I wanted to be a doctor, but it was kind of all in a whim for me. I don't have doctors in my family or anything, so I didn't really know what kind of a doctor I wanted to be. So I was really open-minded in medical school and like the rotations. But I like to be really hands-on, and I really liked women's health and like OB. So initially I was thinking about OB, and I did 2 sub-Is in emergency medicine, surprisingly. But then I realized that like the people that come into EM, there are people that you don't necessarily want to see again, and those are the repeaters. And then OB, I love it. I get a rush from it. Like I just love it actually, but I felt like the lifestyle, and I was kind of scared of getting sued. I'm from Canada. It doesn't happen up there. I was kind of scared of that stuff. And so I thought family medicine had everything. It had people that I could see again, that I could love, I could grow with. And I can do a little bit of everything. I love, urgent care stuff. I did a lot of deliveries in my residency and everything. So that's why I ended up choosing family medicine. So.
I can go ahead. Not entirely primary care, but emergency medicine was added onto this panel. So I chose emergency medicine because I like treating men and women and of all ages. I like all the different components of emergency medicine. So you can go from having an active resuscitation where someone's coming in unresponsive, and the next patient you'll see will be a simple medication refill. So really just being able to see and treat all the different aspects of medicine, having all types of things come in the door every day is a surprise, but it's never a boring day. So alhamdulillah, I've enjoyed it. I continued on to do a fellowship in ultrasound because ultrasound is a growing tool in medicine and specifically in emergency medicine. And so I saw the use of that and I saw that it's only going to continue growing in the field of medicine. So picking a program that had a top-notch program in the country was one of the things that was important to me, but also to get a better handle of what exactly ultrasound is, how is it going to change medicine, specifically EM, and how can it continue to evolve.
Assalamu alaikum. So I did internal medicine specifically because of the flexibility. You can choose your hours. It's an office outpatient profession, and actually, all my life, that has been the best thing. It was very flexible, but you see all kinds of patients, variety. You treat women, children, men, geriatric population, and the instant gratification. So if you treat a cold or cough, or if you treat somebody's blood pressure, it becomes, it normalizes, or if somebody's cholesterol becomes treated, LDL becomes a target, it's very gratifying, it's very fulfilling. So I really liked that part, that you treat little things, you prevent. And I still believe in life that you have to go to the basics, and if you prevention is better than cure. That's what I believe. So if you try to prevent things from becoming big, you're not going to get sick. So that was the reason for primary care. We can't hear you.
My bad. But we've got 3 aspects of primary care, so that's cool. So 3 different perspectives. So the next question is, what does a typical day in the life look like?
I can start for this one. So a typical day in an EM life. So depending on where you work, your shifts are anywhere from 8 hours, 12 hours, or 8, 10s, or 12s. So EM is very much shift work. You come into work, you get sign out basically on all the patients on your side of the emergency department. You take care of any things that need to get taken care of, and then you just basically see patients for the rest of the day. Some days it can be really slow, even though that's a word we try not to use in the department because it's always bad luck. Other days it can be really busy and there's a lot to do. So it's kind of depending on how busy it is, it can be really busy where you're kind of bouncing between rooms all day and all day on your feet. Some days you're just doing procedures all day, working with your hands, intubation, center lines, chest tube, people who come in arrest and doing ACLS or BLS. And so it kind of just depends. The nice thing about emergency medicine is you kind of come in and you don't know what to expect and you just go with whatever comes at you.
So I'm a resident right now. So I feel like with residency, there's all kinds of things that happen. I've done a little bit of everything again. So like OB, I was just in children's Mercy ER last month. So I was doing like a pediatric ER. And then like just internal medicine, we do floor work. And then I did like an ICU rotation. So all kinds of things in the training. But I'm planning to do outpatient. So inshallah, my job is going to be 4 days a week. And I wanted to have Friday off so I can go to Jummah. So Friday, Saturday, Sunday, I'll have off. And I'll be working 4 days a week. And it's 36 hours that I have to do patient care. So like I haven't started the job yet, but it's gonna be 36 hours, inshallah, where you just see patients basically throughout the day. My particular practice, I'm doing prenatal care all the way up until delivery. So I'll be taking care of all the women, and then the babies that come back afterwards. And then I also do colposcopies, so I'll be doing that. They also have a little urgent care there as well, so I'm not sure how that will work. But they said they might stick me in the urgent care, but the rest of the time it'll be clinic. So, we do all ages, diabetes, blood pressure, like I can do skin biopsies or take out stuff or whatever chronic complaints people have, and then all of everything else. So I'm kind of excited to be done with residency. Oh my gosh. And have like normal hours and not be working nights and weekends. So I'm excited.
So you guys have good luck, very good luck with your new job, and ER is very exciting, but I couldn't do it. I had a child already walking into residency, during residency actually, and afterwards. So my day is very predictable actually. I get my scheduled patients. They are usually scheduled for a month or sometimes 2 months. So it's very what I'm saying. You walk into the office and you have scheduled. You start with, we have 3 rooms. And you start one by one. Usually patients are scheduled every 20 minutes. Then we have physicals. So physical is something when you go ahead and you do a detailed exam, detailed history, like you do in residency, everything from top to bottom. So that's usually booked for 30 minutes. The follow-up visits for like high blood pressure, diabetes, hypercholesterolemia, or colds and coughs, they are usually booked for 15 to 20 minutes. And when we do physical, we do EKG, we do spirometry, we check blood work, physical exam, and then we sit down and go ahead and discuss everything. Any acute issues, we deal with it. What else? I do some after COVID, it's actually a little bit before COVID, we started telemedicine, and we have continued to do it. So people who are not able to come into office for some reason, there are certain diseases which you can still treat very, very easily. We learned in COVID, like all upper respiratory, acute bronchitis, unless somebody is not having any bronchospasm, any tightness in the chest, you can easily treat that. Some follow-ups for hypercholesterolemia, diabetes, you can do that on televisit. So there are still some simple things you can do on televisit, and rest of the day, it's still better to see the patient in the office. And then I'm affiliated to 2 hospitals, Hackensack and Holy Name. So if I send a patient, I used to go and see that patient in the office. I haven't been doing that after COVID. I have my friends, my colleagues who would love to do that. So they're doing that part for me. And they update me if I'm sending a patient to the hospital. If a sick patient comes in and I have a chest pain, or if I'm suspecting appendicitis or something, so I send them to the hospital, and my colleagues would see them. I'm using Hospitalist a lot, because that's a very good service and they're very reliable, especially in Holy Name Hospital. They're very good. They're very they communicate. So that's it. So it's very predictable in medicine. No, not much excitement. Most of your patients become your friends after 20, 23 years. I've been in practice for 25 years. So the families, the parents, their grandparents, give children, all have started seeing me. So it becomes a family practice kind of.
Yeah, it sounds like you get to see a diverse array. A lot of our panelists get to see all kinds of conditions in a day. Our next question is, do you currently do any research? Have you done any research? And if so, what does that look like in primary care?
So I'll answer that first. I haven't done any. I have So I'm sorry.
I've done very little research. I've done the amount of research required by my program, as well as enough to get into my fellowship. Uh, Research in residency can take a lot of different forms. Usually, like clinical research is what we do. So, whether it's in the form of a case study, a case report, a meta analysis, reviewing the literature, usually what happens is you have an interesting patient, you develop some sort of a clinical question based off of that, and you end up asking yourself a question. And if you don't know the answer to that and you do a literature search and you still can't find an answer to that, then you discuss it with your attendings or your team or your co-resident or whatever research leads you may have working with you guys. And you can see if there is a potential research study to come out of that. But again, I'm very much not research oriented, so I've done very, very little.
So I don't know, I wouldn't say I'm research oriented, but I did do a master's degree where I did research. So I like to do it a little bit. For my residency, I did have to do a project, and you can get by not doing too much of a project. But I actually took on a bigger project looking at, so in our hospital, we treated COVID patients. So it was the treatment that we used versus another hospital. And so we were analyzing like over 600 patient cases, which took a lot of time. In the end, I ended up using med students to help me analyze all the patient charts and all the oxygen requirements and all the things that we did. And then, we presented it in a poster, and then we're seeing if we can get it into a publication or not, but we haven't gotten to that point yet. And then I also did have some unique cases as well, like skin conditions that still in the process of writing it up as like a case report and like a photo journal entry. So I don't know what it'll be like when I'm working though, but that was all in residency.
Awesome. So it sounds you guys like you see interesting cases and then you
Yeah.
tend to write those up more. Okay, so our next question is, what should medical students looking to go into practice, similar to the way you practice, what should they be focusing on? And what types of things do they need to get really good at?
I would say probably the number one thing, and I don't think this necessarily just applies to emergency medicine, but to all of medicine, and to be honest, in life in general, is like being open to feedback and being teachable. Um, you don't necessarily have to have like all the clinical knowledge, all the technical expertise to go into emergency medicine. People just want to see, especially program directors, they want to see that you're ambitious, you're proactive, you take ownership of the patients when you're on your rotations, and you're open to feedback and willing to learn. At the end of the day, that's going to be like the biggest thing, at least what matters to us in our field. Um, Obviously you build clinical acumen. The more patients you see, the more different cases you see, the more you study, you'll be able to build all the clinical knowledge that you would need for your practice. But like being teachable, that's something that is prized pretty highly within the emergency medicine field. Just because I think within EM there tends to be a lot of strong personalities, and so usually we like strong personalities, but also strong personalities that work well with each other.
So I will say, because I did do 2 EM sub-Is and then I decided it wasn't for me, that there was a lot of men in my sub-I, and then everybody had like these tool belts, and then they were really gung-ho and trying to like get in on everything. And I was kind of not like that. So that's when I realized that even though I like to do procedures, maybe, I don't know, I wasn't like a gunner or anything. So that was one thing I noticed when I was just doing my EM stuff. Not that you need that skill, but I felt like that's how it was when I was trying to do my sub-I. But for family medicine, I feel like for family medicine, honestly, it's a little bit of everything. So on your rotations as a med student, when you're learning everything that you're learning, you just build on that, and with family medicine too, if you're interested in sports medicine or women's health, like for me, or you're interested in like, skin conditions or more elderly patients, like the geriatrics, like you can specialize in that or have your patient panel be towards that, or whatever it is, like if you're good at injections and you want to do like knee injections or like Botox or whatever, like you can build your panel like that, and those are skills you can develop over time. The most important thing for me was building relationships. I really like that. So, you build a relationship with your nurses, with your patients, with your staff, people that you work with. And I felt like that was the most valuable thing. So for me, so if that's something that you like, I felt like family medicine really gave you that. When I was on internal medicine, I will say I felt like I was really isolated, because I would round with the attendings, and you kind of see the patients and then you just don't see them again that much when you're rounding on the floors. And I felt like the attendings kind of like cardiologist works on their own and the nephrologist work on their own. That's kind of how I felt. I felt really isolated and I thought I'd make more friends. But in family medicine, I felt like everybody kind of worked together and it was just really nice. So those are kind of things that I looked for. I don't know if that answered your question, but in terms of personality and things that you're working on as a med student, just like think about where you kind of want to see, how your colleagues are, what kind of patients you want to see. It's just things to think about.
So I agree. I would just add a few more things. Number one, you treat your patients as you would treat your family. So with that in your mind, you have to be friendly, you have to be presentable. Knowledge is important. You have to know what where you're coming from and what you're dealing with. In terms of practice, I think if you're applying somewhere, what they're looking for is your readiness to learn, your eagerness to learn, and hard work. Ease comes later on, but you have to be appearing that you're ready to take challenges. The other thing I would advise everybody is to have very open communication. So if you have a patient with CHF, so you should have your cardiologist's cell phone. You should not be calling their service. I mean, you could, but first time you call them on the service and then you introduce yourself with your first name and you ask for your cell phone and you give them your cell phone. So you can text them, you can talk to them about your patient in the middle of night at 7 a.m., at 6 a.m. So on your patient, however many consultants are, you should have there on your contact list. And communicate and show readiness. You will learn. Medicine is learning all your life, and it'll take 2-3 years after you start practice when you'll be confident and you'll say, oh, I can do this and I feel like a doctor. But the readiness and the eagerness and that would go a long way, and the sincerity to profession. Remember, we are not fixing car, we are not working with numbers and money. We are dealing with live human beings, right? So that compassion has to be there always. Money comes with it.
Yes, sounds like great tips for rotations, especially your medicine rotation. And then the next question is, what advice would you give to the younger version of yourself that was still in training or was still a medical student?
Network as much as you can. I think I did when I was an M1, I was proactive about doing shadowing even in my first preclinical year, so M1, M2 year. And that's when I had like started meeting some people. So the larger the network you build, the better
you're able to use that network. So whether it's on your clinical, when you're on your clinical rotations, make sure you get the names of everyone you're working with. That includes your attendings, your residents, your techs, your nurses, your clerks, everyone that makes your job easy. You should learn their name because people will recognize that you know who you're working with. In ER, you can't get everything done on your own. So it's really a team effort. And so building that network, building that connection, trying to go to emergency medicine conferences, even as a medical student, they give great discounts. Some medical schools even give funding for their medical students to go. There's some lectures and talks even oriented towards medical students at these conferences. And then not only networking when you're on shift, but also like outside of shift. And one of those other ways to do that, again, is with the research. So if you go through the roster of your department at your medical school, you go through everyone. See, usually they have like a portion where it's just like what their clinical interests are. And then you can do a little bit more research about that. And if you get on a project with someone, again, it's really important to build that. You're going to need your slows, your letters, and the more power you have behind your name, especially when you're applying for residency, the better it is for you in the long term. And networking doesn't end. Still did it during residency, still doing it during fellowship, even after fellowship. It's something that continues to be done at all conferences. I do have multiple meetings at this time, so I apologize. I do have to leave right at this time. But the organizers will have my phone number and my email. And if there's anything during the QA, please feel free to send it my way, inshallah.
No worries. Thank you so much for joining us.
You're welcome. Assalamu alaikum.
Alaikum assalam.
Awesome, thank you. So I agree with him 100%. Networking, representing yourself, going, talking to people, that really goes a long way. You go introduce yourself, you show the eagerness, get involved, even if it's something very simple as, bringing coffee, something, a little something. It will be remembered and it will really, basically you have to be courteous, and networking is part of that. You be friendly, you introduce yourself, people will remember you, and that goes a long way.
I agree. And also a part with applying for residency and then also looking for a job too. I know like as a senior this year, I played a role like in interviews and things like that. And definitely people that were like, we always look for people that are good team players or that will get along with others, and things like that. So obviously, knowledge or scores or whichever, like those are all a part of it. But in the end, it's more like how you are as a person and if you'll get along with the people. So, if you are networking or someone puts in a good word for you, that does actually go a long way. Maybe it shouldn't, but really it does. So like if someone knows someone or puts in a good word, I think that made a difference, at least in my program. So.
So our next question is, what did different stages of training look like? For example, what was it like to be an intern, an upper level, and then becoming an attending?
So an intern, I was scared. It was scary. I felt like medical school, I don't know, I never did notes as a student for some reason. And then when I entered, it was during COVID. So we were all like social distancing. We didn't talk to anybody. We wore masks. And I don't know, it felt like we were going into like some apocalypse or something, on top of not having a lot of medical knowledge and experience and stuff like that. So that's what I felt like as an intern. And you're just like, you're on the medicine floors a lot, you're working a lot, like you're doing all the, scut work as an intern, your hours are long, we're switching between night and day a lot. As a med student, you know, we get students right now and we always let them out early. They're never staying that late. But as a resident, you know, you're staying late, you're working on your notes late after already staying late. Inbox piles up, you get called ACLS at nighttime, there's no attending, like where are they? Like it's really stressful actually as an intern. Second year, it kind of feels like, okay, you kind of got it. Now you have new interns, and then you're like, oh, okay, I know some stuff, and you can like tell them things. And then this year I was a senior, and so it felt really different because now all of a sudden the world is like open, you know. I didn't apply to fellowship. I was looking for a job, and so I feel like, you know, your whole life up until now, you're, you know, maybe you had a choice where you went to undergrad or something, but you know, things are kind of decided for you in terms of med school or rotations, residency. Then all of a sudden you have a choice of where you can go for a job. You can negotiate. It's not like, oh, will they take me or not? It's more like, oh, this is where I want to go, or do I want this? You know, it's a totally different mindset. Um, and so third year was really different because of that, like just looking for a job. And it really felt like you are going to graduate, so you're going to lose all the people that you could talk to before for advice and stuff like that. All of a sudden you're going to be on your own. And I kind of think about that sometimes, like, what would I do if I couldn't talk to anybody right now? Or like ask what this is or something. I mean, I think you can still do that when you're attending. You'll have colleagues. And I did choose a practice where I have a larger group, so I have more people to talk to coming out. I chose like not a small practice, somewhere where there's like other specialists and stuff. So it's a community health center. So I'm really excited about that. But those are some things that shifted in my mind as a third year, like trying to fill in all the gaps that I had because I won't have backup later.
So life gets easier. First year is first year. Anywhere you go, basically you just sleep, you work. But that good thing about residency is every single day you're progressing, and it goes through. It does go through fast. You do learn a lot, especially places where you have to work very hard. Um, your rotations like ICU, CCU, they seem very tough, but when you start doing that, when you come out of it, you feel that you've really learned a lot in that month. And if you, most programs have 2 months of unit. So when you go there second time, you would actually start enjoying it. It's tiring, but it can be rough, but a lot of time you would actually really enjoy, especially your ER rotations, you would love it. Some programs don't start ER in first year, but ER is where you're seeing you're the first person to see the patient, and it's a lot of fun. Whatever you've studied, you see that, and it's very exciting. It does get very easy, slowly, slowly. Third year becomes much easier, and then once you graduate, you'll find a lot of, hopefully, but in our profession, you'll find a lot of people who would still be very ready and approachable around you. And again, you go in with a friendly attitude, you'll find friendly people, and you learn and you make friends as you go along, and things become easier, especially because you're sleeping better, your lifestyle is better. So that really helps you.
It's great that we have all ranges of the of training here to go over it. That was great. We actually have a couple questions from the audience. So I'll start with the first one about family medicine. So what advice specifically can you share for M4s on the residency trail? So on interviews with personal statements, sub-I's rotations, and things of that nature.
So like I said, you know, you're going into interview season right now. I don't know what they're doing this year upcoming, like in terms of video interviews or in person. But like I said, I felt like if you had done a sub-I, that really went a long way. So after I did my 2 ER sub-Is, I was like, no way. And then I started doing FM sub-Is, and you know, everywhere you do a sub-I, you get an interview. So I think that is nice. And then when you are doing an interview, just being really personable. This last couple of years, we were doing video interviews, and I did participate in doing the interviews. And I feel like you can really tell if someone's interested, if they're asking questions. And like I would write, like as an interviewer, they would tell us to like write down who was interested or like who asked questions, you know, and it just shows your interest level. If you're just sitting there like nodding, maybe it's kind of like, oh, maybe they're not that interested. Maybe they did 20 interviews and now they're tired, you know. But if you're really asking about the program or like you're inquisitive, like you can tell, like I can tell. And then if you have 15, 20 minutes to talk to the interviewer, some people fizzle out. They don't have anything else to talk about. And then you can kind of tell that, oh, maybe they can't hold an interview conversation. Or maybe you can't, you know, it kind of just depends. But being personable, and then if you have worked, you know, on the rotation or something, people can really gauge if you'll be a good team player or not. And that's kind of what they look for during interviews. And then in terms of letters, I can't really speak to that, but I know for me, I had like a range of letters. So I had like a family medicine one, I had a surgery one, and then I think I had like a medicine one or something. And I had like a research one. I don't know how many you could put in. I feel like I just collected letters over all of my rotations whenever I felt like they could write a good one. And then I think I submitted like a mix depending on the program. But I don't know if that, like, I'm not sure how that plays a role because I didn't look at them for interviews or not. But yeah, you just gather your skills over time, and residency will just be another whole thing.
Great,
And
thank
oh,
you. Oh, go ahead.
and then also like when you're interviewing too, different programs have different unique things as well. So like kind of think about what you are interested in, which part of family medicine you're interested in. Like my residency was more internal medicine and OB heavy. So if you like that kind of thing, I feel like it treats you more well-rounded, then that could be something you're looking for. Other programs might not be so internal medicine heavy or whatever. So you can look for programs like that too.
Awesome, thank you. And that kind of leads into the more questions for family medicine we have from the audience. So what sort of things should students keep in mind when choosing a family medicine residency program, especially with a focus on women's health? And what sort of things are good questions to ask programs and things to watch for on the websites and during the interviews?
So my program did have an OB fellowship and a women's health track. So things that they have talked about over the last few years is that our delivery numbers have been going down. I feel like they've stayed stable like through 3 years that I was there. I feel like without trying too much, I got 50 deliveries. And then you can get more than that if you get more panels, if you go in to deliver them like off shift and things like that, which I did do. But I feel like it kind of just depends on what kind of numbers you're looking for, if you wanted to do fellowship or not. I know the 2 fellows that we got this year, they were like closer to like 100, like 80 to 100 deliveries that they came in with. So it kind of just depends on what you're looking for, and you can get that if you like work harder. So like asking about how many deliveries people are usually getting, but our particular residency, we have our family medicine group, and then we have an OB attending group. And so they do a certain number of deliveries, and then our family medicine, we get a certain number of deliveries. But there's no OB residency, so we're not fighting for those. And then you can assist on C-sections. So like asking about that, like if you can assist during residency, you know, because you get some experience that way. And then like kind of how the hospital set up too. Another thing I liked about my program was that the whole thing was in one hospital. So we have our clinic, we have our labor and delivery, our medicine, like we're an unopposed program. So we participate in everything, and I could get to everything easily. So if I had a panel that was delivering a baby now, I could be like, hey, I gotta go. Can somebody cover my clinic? I have to leave. And it's just like down the hallway or like on the other side of the hospital, as opposed to when I rotated in Detroit, it was like a hospital system. So our clinic, you had to drive from there to like the main hospital or something. So that might be a little bit more tricky if you're going to deliver a baby or something like that. And then, yeah, so I feel like those are things to ask about. Like if there are OB residents that you're competing against, you know, in terms of deliveries. And then for family medicine, we don't necessarily do high risk pregnancies. And then I didn't like, we do rotate in the NICU and things like that, but I didn't deliver babies that were more preterm than 34 weeks. So I didn't do like tiny, tiny babies. They would get transferred out. So if those are things you're interested in, maybe you're interested in like OB or peds or something. But as family medicine, you know, a lot of our things were more routine and like not anything too wild. They might have preeclampsia. That's kind of how far it got, but and then we would do C-section if it needed to happen. I did deliver twins with the OBs sometimes, but usually twins are more high risk pregnancy. So yeah.
Great, thank you. And our next question from the audience for our panelists is, how do graduates network?
I'm not a graduate yet, so maybe I'll give this to you. But I do attend conferences, like our family medicine conference, and I went to the national one in DC this past year, which was great. I felt like you met people all over the country. People are always going to like, you know, they're doing their CME stuff, so they have all kinds of different topics, people from all ages, all practices, all over the country, and I feel like that's a really good place to network. But
Yeah, the conferences, you have to be on top of it, and people around you, your professors, your colleagues, you know, you ask them, you talk to them, and they will connect you to others. But a lot of time you make friends during conferences, and that increases your you know, friendship group, gives you more context. When you're rotating, during your rotations, be proactive and meet people, talk to people. You can start making friends there also. You can start networking from there also.
And our next question is, how much outpatient practice and training did you get during residency, and how much of your residency was focused on inpatient care, and how much was similar to what you practice now?
So it's very different. During residency, unfortunately, we had 1.5 day of outpatient clinic. And that started in second year. So for 2 years in internal medicine residency, I had 1/2 day a week. However, all my life I've been doing outpatient. So I think internal medicine did not give you enough exposure to outpatient. And basically, once you come out of residency, then you learn it. But you learn it. So residency programs, that's mostly I see that's a weakness in there. But that's a fact.
For my program, family medicine, in our first year, we do a lot of internal medicine and labor and delivery, and then ICU and ER. So they're kind of like inpatient rotations. And during those months, we like they always try to do at least 40 weeks of continuity where you're in the clinic. So for 40 weeks out of the 52, you should have at least a half day in clinic. And so on those inpatient rotations in first year, you'll have a half day. And then on the outpatient, we have outpatient rotations. So like endocrinology or something will be like an outpatient, or we have like a pediatric outpatient clinic rotation. things like that, where you'll be outpatient, and then you'll have maybe you'll have a half day as your continuity clinic. So patients that you're seeing as part of your panel, and then you'll spend the rest of the time on the rotation. So in first year, it's like half a day. In second year, it's a full day, or it'll be like 2 half days. And then in third year, it's 1.5 days. So usually it's 1 day and then another half day in third year. And then we have half day for didactics. That's 2 days. And then you have 3 days on your rotation. Or if you're working on the weekend, then you're also on your rotation on the weekend too. So between first and third year, every year you're getting a little bit more clinic time every week. And then when you're on inpatient months, then you're kind of just inpatient, even in third year, because we're like the senior taking care of the floor. But I mean, I felt like, we're set up for outpatient in the end, or inpatient. So I felt like my program was really nice in that way. We have a lot of graduates that will go on and be inpatient internal medicine people, and they'll, round and just do that 1 week on, 1 week off at the end. Myself, I'm doing outpatient, and I really did enjoy doing deliveries, but I'm just not going to do it. But some people, they will go become full spectrum, do deliveries, and then some people will just be outpatient. And then we also get newborn nursery training too. So if you want to pick up like a weekend shift, like a Saturday, and then round on the newborn nursery, for a lot of jobs, actually, when I was interviewing, they would offer that if you wanted to do that, or pick up an extra side gig rounding on newborn patients, you could do that. And I felt like my program really, it was a good balance of everything. So I'm really happy about that. Yeah.
Awesome. So in our last few minutes, I just wanted to open it up to the audience. If they have any specific questions they want to ask the panelists, you can message me. Or if you just feel comfortable asking, you are welcome to, if anyone has any other questions.
You have my email and my contact information. I'll send my cell phone also. If anybody needs any questions, they can email me or text me.
That would be wonderful. I can get it from you, or you can put it in the chat, whatever you prefer. Oh, we can't hear you.
Oh,
I
I'm
can
sorry.
put mine in the chat.
My mistake. Let me put it in the chat.
Awesome. Thank you. Perfect. Thank you. And our last question for today is, if you had like one lasting piece of advice you want people to take away, like medical students specifically, to take away from this panel, what would that be?
I think be yourself, be sincere to yourself and your profession. Always remember that you're treating a human being. So, and you treat everybody like you treating your family. I think that would go a long way all your life. Good luck, everybody. I wish you guys very good luck. Good life, Hasanat of Deen and Dunya, inshallah. You become very successful doctors. And if anything you need from me, I'm always there. Take care.
Thank you. I think for me, I would say, I'm graduating this weekend, and I was thinking about it. I started this medical school journey 10 years ago, guys. I studied for the MCAT 10 years ago. And so I feel like this is a very long process. And so enjoy the ride is what I would say. I know we're always like thinking about the next thing, or next exam, the next thing, or the next after this, after that, but 10 years went by. Okay. So enjoy the whole process, make friends, make sure you have downtime, spend time with your family, travel, do all the things that you love on top of learning all of the stuff that we're learning. But, if you're doing it, you're already doing it, but make sure that you also spend time for yourself, because you know, one day it will inshallah be done and you'll get through it. And then you'll notice that 10 years went by. So just enjoy the whole process. Yeah.
Very true and wise words, I will say, from everyone. Well, I wanted to thank you both for joining us today. Really appreciate it. And then everyone has the contact info.
Good luck. Take care. Bye-bye.
Thank you.
Assalamu
Assalamu
alaikum warahmatullahi wabarakatuh.